Welcome back to the Monthly Mastery Program. Before we dive into today's topic, we want to remind you about the short quiz on this week's material that needs to be completed by the close of business today. A link is included in this email. Now, let's shift our focus to prostate biopsies and reading pathology reports to wrap up the week. Reading. In today's video, we will cover the following key points. First, you'll learn the difference between transrectal and transperineal and targeted versus systematic prostate biopsies. Secondly, you'll learn about the Gleason scoring system. Finally, we'll discuss the components of a pathology report for suspected prostate cancer. In the United States, the standard of care for prostate biopsies is the transrectal ultrasound biopsy. However, there is a shift towards the transperineal approach. Transrectal ultrasound (TRUS) is a quick outpatient procedure that uses sound waves to create a video image of the prostate gland. A small probe is inserted into the rectum to release sound waves, which generate echoes as they enter the prostate. Tissue samples are collected using a needle during this procedure. Transperineal prostate biopsies offer an alternative to the transrectal approach. This method is typically performed under general anesthesia. The urologist visualizes the prostate using transrectal ultrasound and collects tissue cores through the perineum. The transperineal approach is gaining popularity in the U.S. because it has a lower risk of infection and is better tolerated by patients. Studies have shown a significant reduction in complications, from 1% for transrectal to 0.002% for transperineal biopsies. TP approach lets the urologist use advanced imaging to build a true map of the prostate through a fusion process. Urologists employ two different approaches for prostate biopsies, which can provide insights into the surgeon's adoption persona and risk tolerance. The systematic biopsy involves taking samples from predefined areas of the prostate, usually 12 cores in total. An ultrasound guides the needle through the rectum into the prostate, but this method does not target specific areas of the gland. Recently, the inclusion of advanced imaging has shifted the paradigm. Targeted or image-guided biopsy allows surgeons to combine a multiparameter MRI image with real-time ultrasound to pinpoint the specific areas to be targeted. This approach reduces procedure time to 10 to 20 minutes and improves accuracy in detecting significant cancer in the prostate. Data is emerging to support the decrease in overdiagnosis and overtreatment with this method. For instance, the Precision trial showed the potential to cut the overtreatment of prostate cancer in half. One significant development in comprehensive prostate cancer programs is ExactVu, which we will explore in detail later this summer. It has revolutionized the field and warrants in-depth discussions of its nuances. Some urologists may request a multiparameter MRI from the patient to better target concerning tissue. When combined with real-time ultrasound imaging, this fusion approach comes in three types: cognitive fusion, software fusion, and in-bore fusion. Cognitive fusion involves the urologist mentally comparing the MRI image to the ultrasound image to identify the targeted tissue. Software fusion utilizes a platform to combine the images into a 3D map of the prostate, providing an accurate representation of the gland's location, size, and tumor shape. In-bore fusion involves placing the patient in the MRI gantry and using the MRI image to guide the biopsy procedure with a transrectal needle guide. Let's now dive deeper into the Gleason score and the various metrics used in pathology reports to better understand prostate cancer. The Gleason score is a way of describing prostate cancer based on the abnormality of cancer cells in a biopsy sample under a microscope and their potential for growth and spread. In most cases, prostate cancers consist of cells with different grades. The Gleason score is calculated by adding together the two grades of cancer cells that make up the largest areas of the biopsied tissue sample. Typically, the Gleason score ranges from 6 to 10. Gleason grade 1 and Gleason grade 2 represent well-differentiated prostate cells, meaning that the abnormal cells closely resemble normal prostate tissue and have a uniform appearance. Gleason grade 2 tends to have more space or stroma between cells. These grades are not usually used to describe cancer because they represent tissue that almost looks normal and isn't considered cancerous. The lowest possible Gleason score for a cancer found in a prostate biopsy is 6, indicating a lower risk of spreading quickly. On the other hand, the highest score of 10 suggests a cancer with a greater risk of being aggressive. Gleason grade 3 signifies moderately differentiated prostate cancer. The cancer cells appear less like normal prostate cells and exhibit increased cellular abnormalities, especially at the margins. While still considered a moderately aggressive disease, grade 3 cancers have a higher potential to spread outside the prostate. Gleason grade 4 indicates poorly differentiated prostate cancer. The cancer cells are significantly abnormal in appearance and exhibit more aggressive behavior with a tendency to spread beyond the prostate gland. Grade 4 cancer often demonstrates a higher growth rate compared to grades 1 to 3.
Gleason grade 5 represents the most aggressive and poorly differentiated form of prostate cancer. The cancer cells bear little resemblance to normal prostate cells, exhibiting severe abnormalities. Grade 5 cancer grows rapidly and has a high likelihood of metastasizing to other parts of the body.
When reviewing a pathology report, you will come across several terms such as core, core length, core involvement, grades, and Gleason score. Let's examine each of these metrics. The core refers to a small cigar-shaped sample of prostate tissue that the urologist takes during the biopsy. Each core is defined by its length, and the validity of the sample is determined by its length. A minimum threshold of 12 mm is often considered significant. Studies have shown that longer cores exceeding 12 mm have significantly higher detection rates, 39%, compared to cores shorter than 11.9 mm, 23%. After the biopsy, the cores are sent to the pathology department for evaluation and grading. Each core should include information about the zone and position from which the sample was taken within the prostate. Core involvement is a common term you will encounter. It refers to the percentage of the core that shows malignancy. This metric helps the urologist understand the seriousness and aggressiveness of the disease. Each core is assigned a Gleason grade, ranging from 1 to 5, based on the cell structure observed in that particular core. Since most prostate cancers contain cells with different grades, each sample will have 2 grades, highlighting the primary and secondary cell patterns. The first number represents the most prevalent pattern in the sample, while the second number indicates the extent of infiltration by the second most prevalent pattern in the sample. By understanding these key metrics, you can better navigate and interpret pathology reports, providing valuable insights to support the urologist in planning treatment and determining prognosis for patients.